Good morning, everyone. Good to see so many people. My name is Rasmus Hannemann Moller, and I'm responsible for global marketing at Coloplast. And at Coloplast, we really want to make a difference in users' or patients' lives, and we want to make a real clinical difference. That is basically what we strive to do through our products and education. And we achieve that by working with you guys as our most important partners. Specifically in continence care, we're focused on reducing the burden of bladder management. And we believe that a very important part of that relates to the adherence to treatment. So therefore, we have these types of events today, and therefore we're asking you to fill out questionnaires, and you can actually fill out the first page while you are pretending to listen to me. And we will actually collect that information and try to summarize it and feed it back to you guys in some type of publication. But the idea and what I'm trying to say is that it's very important for us to understand important topics like this, adherence, to reduce the burden of bladder management, so that we can continue to improve the education and the products that we develop. So today I have with me two great speakers, Dr. Klasikov and Rune Nørager, and they will take you through some very interesting different aspects of this. So please welcome these two guys to stage. Thank you.
We're on. Good morning, everybody. Thank you very much for introduction. Dear colleagues, friends, we hope you are here for a good, enjoyable, scientific and behavioral ride for next hour. We would like you to be with us as active participants. We want your responses. We want your participations. You have a challenge. You have to listen us and immediately do multitasking, answering questions. We will give you time. Please be oriented. You have two cards also in your seats, red and green. And we will ask your opinion during our presentation on a regular basis. We want you to be participants of these meetings. Who I am? I'm Andrei Krasikov. I'm professor of University of British Columbia in Vancouver. I'm a clinician scientist. I do both basic science and clinical research. And also I'm a physician at the Regional Rehabilitation Center. That's why I'm really trying to manage my life between research and clinical job. And it's a great pleasure to present to you today and hopefully ask your opinions about the most crucial and difficult sometimes challenge to manage bladder in individuals with spinal cord injury. And I have today with me my colleague.
Thank you very much, Andre. My name is Rune Nørager, and I'm a behavioral psychologist. And in my daily work, I work with companies helping them design technology that fits how human beings really are and not how we think they are. There's actually quite a lot of discrepancy there. And today I'd like to share one of the tools I use on a daily basis to help companies achieve that. And through 5 themes, considerations, we'll be looking at how that tool might have an impact for the work that you do on a daily basis with your patients.
We already outlined to you what is happening with respect of technical aspects of the symposium. Please do fill questionnaires and please leave it at the end with our colleagues from Coloplast, because we hope that shared opinion, what we're trying today to obtain, will help us eventually to have some kind of international picture, what we're doing in Canada, what we're doing in Germany, what we're doing in Africa with respect to bladder management in people with spinal cord injury. And our objectives today following. We will briefly describe to you what is neurogenic bladder. We are all experts here, that's why we will not state a lot in the details, but at least general picture. And what are the major presently challenges or rules for management of neurogenic bladder following spinal cord injury. And we'll also outline some identifying in the literature concerns and challenges why our patients have difficulties to adhere to specific bladder management protocol following discharge from the hospital.
Mm-hmm. And then we'll introduce this behavioral model, and we'll be using that model to explore those clinical findings. what kind of insights might that behavioral model give us that can help you achieve your goals with your patients? And we'll be exploring 5 key considerations for how you can improve adherence to treatment with that behavioral model.
And again, we would like to keep you alert and engaged and be active participants of this symposium. Let's start. You know this picture very well. Very complex, very unusual organ in our body, which has a multiple system, complex innervations. When you ask medical student or resident, tell me about the bladder. It's a ball, and sometimes it's all what they can tell, but we do know how complex this organ is, and complexity of organization, complexity of connection within the nervous system allowed it to be wonderfully functioning when everything is working fine. Unfortunately, when pathology will occur, injury occurred at the spinal cord level, injury occurred at the brain, injury occurred at the periphery, this system doesn't work very well. And definitely both individuals who are suffering from neurogenic bladder and we as the clinicians have a significant challenge. One of the major aspects what we as a medical community do know in order to manage this specific condition as well as other conditions in the human body, we don't want to have complications which are demonstrated in these 2 sections, hydronephrosis and so on. What we learned from many years of management of neurogenic bladder following spinal cord injury, we do know there is a disbalance between function of the bladder muscles and sphincters. We do know that there is a sometimes unnecessary and dangerous increase of intravesical pressure, which cause significant changes within the through urinary tract. There is developing of reflux. There is a possibility of developing of hydronephrosis. We do know that long time ago we saw a significant number of individuals with spinal cord injury who developed renal failure, required management additional such as dialysis, and unfortunately, about 20 years ago, we lost significant number of individuals with spinal cord injury due to death of renal failure. Interestingly, that time is changed when we clearly understand what has to be done for the one single issue with bladder, regular emptying. An introduction of catheters definitely revolutionized our understanding and management of these individuals. We definitely saved a lot of lives with this respect. That's what we have at the present time with respect to our guidelines and our tools to manage neurogenic bladder. And I will not go in detail through each of these methods. We do know all of them. And then the choice, how we prescribed and how we deciding what to recommend to our patients at the end of the day during rehabilitation, based on many, many factors that even in the medical community sometimes will be discussed and challenged. And one of the interesting aspects is that I believe common goals for management of the urinary bladder in our mind is that we have to select the most appropriate management plan for specific individual. I believe we also clearly understand that educate the person why he or she has to do this management for urinary bladder is one of the common components of the tasks that patient will buy into this management protocol. And finally, we clearly understand that we have to engage and have some kind of points of follow-up with individuals with spinal cord injury who has neurogenic bladder in order to follow up to see, prevent possible complications, to see how or she is doing, and obviously this follow-up plan is very crucial. We identified multiple factors that could influence options for bladder management among our patients. And I will not go in detail through each of them. Many of you clearly know these aspects when you see a first-time person with spinal cord injury, and we clearly know that, C5, poor hand functions, Foley catheter, suprapubic catheter, intermittent catheterisation. Young man, T10, complete injury, fantastic hand function, no brain injury, probably intermittent catheterization is the best practice, and most important, that we do have guidelines. We have a very well-developed guidelines among the physicians. We have guidelines developed by our nursing colleagues, and the major points of these guidelines that we have at the present time, that I hope majority of us agree, is that use of clean intermittent catheterization for emptying of the bladder among the gold standards of management of the neurogenic bladder at the present time. And obviously, we do clearly understand that the preferable opinion among the both physical medicine rehabilitation specialists, urologists with whom we're working very closely with goals of proper management of the bladder, are the same. Catheterization, appropriate catheter for each individual is crucial. However, we learned a lot, we changed our practice, and I will show you in a few seconds how we changed practice in the last 30 years. We do know that unfortunately, still, each bladder catheterization method could result in some complication. And you just see here, these two lines represent complication rate among the users with urethral Foley catheter or suprapubic catheter. And data which show that individuals who are using clean intermittent catheterization or spontaneous voiding, as you can see, frequency of complications much, much lower. It's obviously a good message for us. But what's happened with our mind during the last 30 years, and this study showed very elegantly, look at the data, how often condom catheter was recommended in the 1970s, and then 30 years later, frequency of recommendation of condom catheter decreased dramatically. Interestingly, frequency of indication and prescription of clean intermittent catheterization during the last 30 years increased dramatically. This is how our mind changed during the last 30 years. However, if we will follow our patients for 30 years and look what is happening with their decision of bladder management, if we will start on individuals on a dwelling catheter about at the beginning of spinal cord injury, 30 years later, 45% of the individuals with spinal cord injury will be on Foley catheter. Interestingly, is that if we start individuals on clean intermittent catheterization, individuals who survived for 30 years, unfortunately only 14% will stay on the intermittent catheterization. What's going on? In other data from the same study, if individual 100% of people who started on clean intermittent catheterization, only 20% of individuals will adhere to this recommendation 30 years later, as you can see here. However, 100% of individuals who started on indwelling catheter adhered up to 70% 30 years later. What's wrong with this picture? Why it's happening? That's why we will try to explore at least 5 potential issues that in our mind we found through the literature, through the evidence, influence adherence to the bladder management protocol in this population. Rune?
Thank you, Andre. Yeah, as a non-clinician, I think the picture is pretty clear that there's room for improvement, there's room for doing better with your patients. So let's explore some tools that might help you do that. So first, we need a behavioral model. As professionals that work with human beings, we need a model of how human beings work. And I meet a lot of practitioners, engineers, software developers, doctors that work with human beings. And they often have this idea about how human beings work, that human beings are rational, that we are driven in our daily life by rational intellectual thought, and we can cater to those intellectual processes. I'm pretty sure that you'll agree with me that this might not necessarily always be the case. So we need a better model of how human beings work. And let's have a look at a good candidate for that. This is Daniel Kahneman, one of the only psychologists to get a Nobel Prize. It was in economics, but that's okay. He says that our daily behavior is exactly not governed by rational thought. Instead, much more basic processes are driving our intuitions about how to navigate in the world. You probably read his book, Thinking Fast and Slow, as it can be found in most airport bookshops. But let's have a look at this book that he wrote, and actually he's just part of a huge research community that is overturning this false assumption about how human beings work. So this is the sort of simplified version of what Kahneman says. He says that we have this very basic System 1 process going on. This is our daily being in the world. This guides our intuition. On top of that, we have the System 2 intellectual processes. These are the resources you use to fill out your tax receipt, play chess, and other demanding intellectual activities. As you can see, there's a skewed distribution between those two resources. The orange basic resources are much more abundant than the intellectual resources. And it's those two resources that I think is the key to understanding some of the behavioral issues that feeds into adherence issues. So let's have a look at a couple of more dynamics that goes on here. We also know that the basic resources, the System 1, they are black box. We have no insight of what goes on there. We need scientific research to open that black box, and that is exactly what Kahneman and colleagues have done. Only the System 2 resources are conscious. Those we can address in a dialogue with patients, and they can talk about them. But the basic System 1, not accessible to what we call phenomenological introspection. Let's put this model into work, and I'll add some more details about it as we go along. But now I'd like to bring this model to your everyday life, so it will get nasty, so bear with me. This is an oven, and we often see that when people need a cold oven heated to 200 degrees, they sometimes turn it all the way to 250 degrees. Not the desired 200 degrees, but all the way to 250 degrees. Why is that so? It's a bit odd behavior. Well, it turns out that everyday people have an intuition, a System 1 intuition about the oven, that heat might be pretty much like water. And we know from interacting with the water tap that when we open it way up, the glass fills much more quickly with water. And we take that insight from water and apply that to our interaction with the mystical oven. So we turn the oven to 200 degrees because then it will heat faster. Makes sense? Maybe you have done it yourself. There's a problem with that. Heat is nothing like the water tap, so it's a false intuition. But I cannot tell you, you won't trust me, because you see, your mental model is immune to my information. And that is the case with your patients as well. If they have wrong mental model, wrong subconscious mental models, they will basically be immune to what you're trying to tell them if it doesn't fit that mental model. So we need to address the mental model. And the mental model lives down in the subconscious System 1, so we need to bring it out into the open, to the conscious level. And you can do that by having patients draw their intuitions. Please draw how you think heat gets into the oven. Please draw how you think your bladder works, or you can ask behind their thoughts. So there's a tool for bringing the subconscious mental model into the open, and then you can start to address the mental model and say, well, actually, the oven is nothing like the tap, it's more like a thermostat. It just closes off the heat when it gets to 200 degrees. And that will then be part of the new intuition that might feed a better rationality about the oven. So let's take this to the intuitions about the bladder. This is what I saw in school. This is what I find when I go to Google and search for bladder. This feeds into my intuition of how my bladder works, and I call this the gas tank mental model of the bladder. My bladder is an open cavity that sits in my body. Sometimes it's empty, sometimes it fills up a little, half full, and then it can be completely full. I can drain a little and then empty it. But basically, it's an open cavity. I'm pretty sure that you can see why this mental model might have some adverse intuitions. Why should I need to exercise my bladder? It's a rigid gas tank that just sits there, sometimes with air in it. So you need to address your patient's mental models, bring it out into the open before you can change their behavior about what to do with their bladder functioning system. And maybe you can provide rich illustrations that a bladder is actually not like a gas tank. It's more like a dynamic muscle. I know from speaking with some of your colleagues that you use rich illustrations like blowing up a latex glove and then deflating it again. That's provide a rich inspiration for how to consider my bladder differently from what I have been taught all my life in school and on Google. And that will then become a new mental model that will become part of the basic intuition that drives what patient thinks is a good idea. And maybe then you can get further with what you want with your patients. I wanted to understand how big an issue is this really, so I took this task to my students at the IT University in Copenhagen. They're pretty clever students, I might add. So they are maybe not representative of the average population because they're that bright, but I asked them, please draw the bladder and urethra on these silhouettes here. And I'd like to share some of those results. This is an overview of some of them, and let me zoom in on one of them. So, Andre, I'm not a physician here, but does this look right to you?
It's a very interesting drawing. I'm quite impressed with position of the bladder in a male model somewhere in the rectum region. It's quite interesting localization. And then I'm quite impressed with this idea of bird's cloaca, where rectum is connected with urethra. Interesting.
Mm-hmm. And here is another one.
Even more interesting, double bladder. We need second bladder, absolutely. Great.
It might be a Danish bias, I don't know, but I like to take this task to a more sort of representative collection, but I'm pretty sure I'll find the same thing globally. So we found these common misconceptions. Some will dual bladder, the straight up urethra, and some will way off, you might say. So I think this is really important, but really we want to ask you, do you believe that patients' misconceptions on bladder function is a key driver affecting adherence to bladder management? So if you believe yes, please use your green voting card, and if no, please raise your red voting card.
Okay, look, we have unanimously, oh no, somebody, change opinion. Red, okay, we have few disagreements, but in the majority of us agreed that looks like if person with spinal cord injury comprehend what is bladder function and structure is, it will help to adhere probably for treatments that we recommend. Great, mark these points. If you disagree, wrote your response, what you believe is important, please do it in capital letters. I'm guilty, my writing are horrible, nobody understands it. Capital letters, please.
Thank you. So, timing, I believe that this is you, Andre.
That's what is another aspect with respect of bladder management or implementation of some therapeutic procedure. Timing. When we introduce management, timing of education, timing how much we spend with the patients are very crucial components in order to communicate correctly with the patients. What we do know about how actually individuals with spinal cord injury or patients will comprehend and will receive the information. And this is interesting data from one of the studies which demonstrate when and how knowledge of individual with spinal cord injury changing with respect following the spinal cord injury. And you can see there is a dramatic progress of amount, total understanding what's happening with my body from the moment of admission to rehab until moment of discharge. Interestingly, is that following discharge into the community, knowledge does not change significantly or even decrease. So based on this data, it is probably our most important, most crucial time of interaction with patients during the early stages of discharge, of admission to rehabilitation. And at this time, you have to clearly remember how much information we have to put into the poor heads of our patients from the moment spinal cord injury function change, motor function change, sensory function change, bowel, bladder, sex, cardiovascular, name it. We have to put all medicine into the person heads, and probably we're thinking that it will be kept for the rest of their life. However, we have to realize practical reality of modern medicine, and this is one of the unfortunate things what's happening with this precious time during rehabilitation. This study collected data from many countries with respect of length of stay during the acute rehabilitation. One of the most precise and large data analysis was conducted through the US centers. And as you can see, during the last 10, 15 years, what we see it in Canada as well. Length of stay shortened by 50%. This is the most valuable time for our interaction with patients. But looks like we're losing the battle. This time is shrinking. And then obviously, there are numerous studies also identified the following points, that education, time that we spend with patients on this issue, significantly improves their satisfaction with treatment, satisfaction with rehabilitation, and increase quality of life. There is also very interesting data on documentation that when we involve our patients in direct care, they are much happier. The longer will adhere to what we're preaching to them. Further, times that we spend with our patients directly related again to their happiness with information that's received. Can you imagine that patients will rank times that we spend with them to our clinical capacities? You can be a bad doctor, I hope we are not, but you spend with me longer time, I'm much happier with you. And this we have to keep in mind. So by the end of this short time, what you can imagine our patients feel, oh my gosh, how I will keep all this information to the rest of my life. And they need help, and they're asking for the help. And that's why what we do with this, how this information will proceed further. Mm-hmm.
Thank you. So it seems that you have an educational window of opportunity with your patients that is getting smaller and smaller and smaller. So how do you get the most of that shrinking window of educational opportunity? Let's return to the behavioral model that you saw earlier. Here it is again. We have this distribution between the blue intellectual resources in the system 2 and the very basic system 1 resources at the lower part of the pyramid. This model and this distribution between those two resources is actually not always looking so. It looks this way only when we are in a zen mode, when we are relaxed and not stressed. More often than not, the intellectual resources are diminished because you see, they're very fragile. They succumb to stress and other challenges. Even when we're just multitasking, it taxes our intellectual resources. So when you are in a hurry in the traffic and you need to operate your GPS, that's when everything breaks down, although you can perfectly well use it when you are at home in your garage and starting the trip. So stress is harmful to intellectual resources. And your patients are likely to be in a lot of stress during rehabilitation. So you need to time the kinds of information that you feed to your patients. So even a simple message can take a long time to absorb and understand when you are in a distressful state simply because you do not have access to intellectual resources. So this is a very crude version of the model. It's likely to fluctuate wildly. So we think that it might be worthwhile to check with your patients. Are they in a distressful state, or are they in a state where they have maybe more access to the intellectual resources, and then fit your education to that? Because you might be wasting your time if they are simply not capable of taking in what you're trying to educate them in. And maybe there are different kinds of material you need to educate them in. Some is more simple, and then you can administer that when it doesn't require the same amount of intellectual resources as other more complex material. So, we would like to ask you, when initiating a patient's education, do you consider currently his or her stress level?
That's it. If yes, please show us. Okay? Fantastic. That's a quite again significant number of people will adhere or adhere to address stress level, but there is about 15 to 20 people who believe that they don't address these issues. Great. Mark the points. Dear colleagues who are standing, I do appreciate you have a strong legs, but we have few seats here. Please come front. That's why what you actually, next.
Sorry, it's me. Thank you. I'm not off yet. The next theme, we look into contexts. And to bring this theme to you, to something that you can relate to, I would like to have you consider when you first got your smartphone, the very first smartphone. There was a lot to learn about, well, what is this Snapchat thing anyhow? I don't know if you're using that. What is this banking app? What is this and that app? A lot to learn. But actually this learning has two sides to it. So let's use the behavioral model. The learning has a what and a how. The what is figuring out what is bowel management anyhow. And the how is, how do I do it? And in rehab, your patients, they learn both. And also with your smartphone. So they learn the what and the how. Check, check. So you have learned that with your smartphone. Now imagine for a moment that you were to borrow the smartphone from the person next to you. I won't ask you that, so calm down. That smartphone would do exactly the same as your smartphone. Have the same features and functions. But you would need to operate it in a different how manner. So despite that it's doing the same, exactly the same as you already learned with your own smartphone, you need to relearn the whole how part. And unless you put in a lot of effort, you will have a diminished learning and realize less of the what curriculum. And if you then switch to a third smartphone, you'll learn even less unless you put in a lot of effort. So if we take this relationship with the smartphone that you can probably empathize with, or maybe it's your computer that you switch, if we take that to a patient with a spinal cord injury, they certainly have a lot to learn. I looked into the curriculum and it's quite large. But they learn that in rehab. So they learn the what and the how of managing your life with a spinal cord injury. But that is, they learn that in rehab. Now they transition to their home situation. It's still exactly the same what, more or less, but the how can now be very, very different. And that is a challenge. So they now switch to their work situation. New how arises, even though the what curriculum might be quite similar to what they learned in rehab. And unless that we want patients to realize less and less of what they learned in rehab, we need to support them on the how part for each transition into a new context. So similar to the challenges of switching to another brand of your smartphone, the switch from one context to another for a patient with a spinal cord injury poses a whole new set of how should I do this? They know exactly what, because they learned that in rehab, but the whole how part is now different and needs to be relearned and figured out. And you need to support them in doing that. Now I believe it's you, Andre.
Okay.
Thank you.
Thank you. Ron outlined very interesting aspect of ideas in our psyche that we functioning, which depend on our knowledge in different situations, different environments, differently. And here I'm talking right now back as a physician. What are the crucial aspects when we planning rehabilitation process for person with spinal cord injury, which starts in the hospital? On day one, we're already thinking where he or she will be eventually later, walking, living, and so on. That's where we're starting to think about possible environments where a patient eventually become a person in society. We're also thinking what are specific environmental issues, surroundings, communities where a patient will go will be quite different if person discharged to the urban environment or to far away in somewhere without physiatrists, without nurse, and sometimes there are situations when this is happening. And obviously, we in our mind immediately trying to identify what are the barriers the person who is in a safe and secured and supported space at the present time in a rehabilitation center or acute care center will eventually end and face realities of the life in the community. And therefore, I believe, I hope we all agree that we start discharge planning, preparation for this very crucial aspect from the day one. And I hope majority of us face the situation of patient anxiety, living secured, well-established environment when I was in the hospital, going to the community, which is many, many unknown issues. And therefore, our goals of learn the skills, continue to understand what's happening with your body for the patients, for the caregivers, and for the people who will take care of them in the community, again, start early. And here's a possible big laundry list of possible barriers that we already some kind of outlining in our mind what person with spinal cord injury could face. One of them, I will just touch on one of them. How often we talk about, do you have accessible bathroom or shower in your home? No green cards, just, yeah, we do have to talk. If you're going to university, is your school has accessible bathrooms? And sometimes they're not. And that's why here we have to think about these crucial aspects, what this environment will be in the future. In my hospital, before we'll start voting, for example, we will organize home visits. In the middle of rehabilitation, we will send patients to live for a weekend in their home environment. We will have a one-day staying in a hospital family room where he or she can spend with their partners without medical support, a trial. Are you comfortable to be alone? And therefore, that's why we're asking you to vote. Do you use and providing support during rehabilitation to your patients for transition to the community environment? That's the first part of the question. Do you provide this transitional support? Yes, green. 100%. Perfect, we totally agree. However, we also will ask you to answer points or add your comments. What are the possible ways you are preparing your patients for the transition in new environment, which could affect our plans for management of their care in the future? Is it visits home? Is it family room? Or something totally which we don't know? Please share your opinion. We give you 15 seconds.
Thank you, Andre. And again, all this data will be shared with you, so we are collecting data for the whole community. The fourth consideration is about rewards, short and long-term rewards. And to ease you into this consideration, I'd like to share some insights from a user study I participated in. We looked into two different patient groups, patients with diabetes and patients with hormone deficiency. They both need to take injections on a daily basis to get their medication, hormone substitute and insulin. When we talked with these two patient groups, they had totally different behaviors in relationship to their pen. The patient with diabetes hated their pen. They were likely to skip an injection now and then. The patients with hormone deficiency, on the other hand, loved their pen. They would never, ever skip an injection. Why is that so? Completely the same medical device from the same manufacturer, but two very different behaviors. Let's use the behavioral model to look into this. You see, patients with diabetes, their reward for taking an injection on a daily basis is something like 20, 30, 40 years down the road. If they adhere to their treatment, they won't suffer from this and that. But on a daily basis, they don't get any rewards. It's only the nuisance of injecting and pricking yourself with a needle. If you suffer from hormone deficiency, you don't have any energy for doing anything. You can't even get out of bed. The moment you take your injection, on the other hand, you're being revitalized. It's like pouring energy into your body. So they are instantly rewarded when they take their medication. So they have a daily instant carrot felt at an basic system 1 level. Patients with diabetes, they have to intellectually appreciate their treatment and the returns they might get sometimes into the future. So if you take this scenario to your patient group, patients with spinal cord injuries, this is a normal bladder function. This could be me. At some point during this day, my bladder will communicate to me, only you need to visit the bathroom. I will do so, and I'll relieve myself, and I'll have the reward. Ah, what a relief. That is my carrot, and that strengthens this whole behavior loop, so I'll keep doing this in the future. Now this complex bladder functioning system has been put out of work. I have very different sensations, and certainly not the same kind of explicit and here and now experience that I used to have with a normal bladder functioning. So there is maybe no cue or different cues. I have no routine, and I might not feel any reward for going through the cumbersome routine of relieving myself. This feeds into a very fragile behavioral loop. And again, maybe we are best at providing patients with spinal cord injuries the long-term sticks and carrots for adhering to their treatment and management of their bladder function. So the challenge is, how can we introduce a new daily carrot for your patients? And I'm sorry to say, I don't have the answer, but I've spoken with some of you, and I know that you have daily best practices for doing so, because you want to do the best for your patients. So you have explored how can we provide this daily carrot with your patients. And we'd very much like you to share those best practices. And we'll make sure that they'll be distributed to all of you. So how can we introduce a new daily carrot at the very basic System 1 level?
Thank you, Ron. I love the carrot idea, and I don't think so I have answers to the question which Ron raised, but definitely we do know that in medical practice, we do using few carrots and few sticks, that we're either using education tool versus forceful putting knowledge. You have to do this. We're obviously using positive reinforcement with our patients, and therefore keeping this stick, you have to do this, that eventually 30 years down the road, you will be fine, or do this. What is working? What is not? And one of the things which I do know many of my colleagues and my teachers went through the medical school, scare tactics. If you don't catheterize, you will develop hydronephrosis. If your bladder functions managed badly, you will develop autonomic dysreflexia and a stroke. And this is a case from our colleagues from Spain. If you do not manage your bladder, and we do know that 90% of people who develop autonomic dysreflexia due to poor bladder management or something happened with the bladder could develop elevation of blood pressure up to 100 millimeters of mercury, which in the literature suggestive this could be a deadly force. Or I try to be a happy physician. I'm a happy physician. I love my patients. If you're doing everything well, you feel well, you have a great health, and you will end in Paralympic Games. This is our Canadian star who just got his Olympic medal, gold medal in a wheelchair basketball. This is what is a challenge. Stick, carrot, positive reinforcement. I don't have an answer. I'm sharing experience. We would like to know your opinion. How do you motivate your patients? What tricks you do have in your pockets to help people with spinal cord injury to follow up our advice? Write in capital letters your wonderful thoughts and ideas. We give you 1 minute to complete this answer. Please do so. And obviously, as we mentioned, we will share all this information with all folks around the world. Please do so. Okay. Okay, The last concept we would like to introduce to you: who is the most crucial person in a discussion with person with spinal cord injury, with delivering information, with teaching about what's happening with your body. And one of the aspects which I would like to raise to your attention, the issues. Information is enormous. We're trying to speak LA terms, but unfortunately data showing that significant number of patients, and this data coming from United States, do not understand us. Why? We're spending so much time to interact with our patients. This is the data coming when literacy level of patients is not considered. There is up to 78% of people who have less either language, knowledge, or differences in communicating, have difficulties to understand why this prescription was given to me. And they live in office of physician. This we have to keep in mind. Are we talking overhead to our patients? Is this information is overwhelming? Or delivery of this information is missing the point? That's why we still have to keep in mind we are primary message delivery. We are first time meeting patients after the events or developing of disease, and that's why it's our important task to deliver the message to the person who needs this message. However, do we have other individuals who could help us in communicating with our patients the most important aspects of care of spinal cord injuries, such as bladder? And we do know from literature, hopefully from our personal experience, when person who is on wheelchair, who had his or her own experience with bladder management, start to talk with newly injured individuals. Peer support, education through the peer system, and evidence and research showing is a very crucial. And newly injured individuals are reaching to the people with experience. Oh, doctor, you have no idea what you're talking about. I go to talk with my friend who I met in the cafeteria who is on wheelchair. He probably knows more about bladders than you do. That's why definitely there is a very clear evidence in the literature that involvement of peer support in education and support of people, newly injured individuals with spinal cord injury, is crucial component to deliver message to the person. That's why right now we will ask you again, red or green card, do you use a peer support during your education of patients? It's about 1, 2, 3, 4, 5, 6 only card red. Great. Majority of us do use peer support. Can you estimate approximately time or percentage which you allocated or which you think in your mind is most appropriate for the peer support in your rehabilitation strategies? Put the number what is coming into your mind. Is it division 50-50? 10%, 15%? What is your experience? Question? To different people, and that's why you will calculate total have to come to 100. I'm lost, right?
Okay. I'm very happy to see that so many of you use peer support. I would like to look at peer support from this behavioral perspective to provide an explanation for what is going on here. And to do so, we need to have a look at actors. This is the same actor, actually. And he's using something called method acting. You see, to understand a role that you need to play, to get into the mind of another person, you cannot read about it. You can get a bit farther if you talk to relevant persons, but to fundamentally understand and empathize with a person, you have to be in that person's world. And the way you are in a particular world is also being with your body in the same way in the world. So this is why he either loses weight or gains weight. because his body will inform him about what is meaningful in the world. It will give him a certain perspective on the world. And we can take this insight to peer support. Here we have a lung specialist, and he's trying to empathize with one of his patients that has a chronic lung obstruction. He's breathing through a straw, so he's trying to put his body in the same world as the world his patient is in. When he's breathing through a straw, this small ramp here will seem like a mountain he needs to scale. Because with reduced access to air, you get easily out of breath, and halfway up this small mountain, the ramp here, you'll have a dying sensation of being asphyxiated. So being in the world differently with your body, with your system 1, fundamentally changes what makes sense to you. So if we look at the behavioral model again, and we have a person here in a wheelchair, this person is in the world differently, or is in the world in a certain way. And that being in the world with the system 1 resources feeds into what makes sense at a conscious level. So you might say that being in the world in this way constitutes a certain kind of mental models, as we addressed before, mental models that are derived from being in the world in a certain way. As an able-bodied person, you are in the world differently with your body. And that will feed into a different kind of perceiving the world. In psychology, we call this embodied cognition. Thinking is not just something that occurs on the top floor. It is being driven by our bodies and our bodies in the world, both socially and physically. So being in two different worlds in this way can constitute a barrier to some themes that are relevant to discuss with your patients. So it would be nice if you could talk with someone that are in the same world as you are, that has the same kind of rationality and this fundamentally deep level of intuition or resonance, you might call. And there are. They're not just in the same world, they are actually sharing this world. And this is why some themes in educational support lend them better to peer support, because they have this shared fundamental, deep, meaningful resonance. So this was the last take on the behavioral model. It was a simplified version, but it can be used for so much more. So hopefully you will dig into it on your own, and we'll certainly be sharing these insights.
That's why at the end of our symposium, we would like to give you our last thoughts and ideas. That's what we hope we achieve today, that following this seminar, you will take home message that we have to explore mental models when we're talking to our patients.
And you need to choose the appropriate timing for delivering the information to your patients.
And I hope when we're doing our interventions with patients, recommendations, we will keep in mind concrete goals, carrots, what is achievable with this specific management.
And then finally, match the message and the messenger. Use peer support.
Again, at the end, we would like both acknowledge our disclosures, our support, research, and different affiliations that both Rune and I have, and we hope you complete your questions. We're exactly on time. We also would like to invite you to Coloplast booth, where both Ron and I will be present during the meeting, and happy to discuss your other questions. Please complete your seminars. And again, thank you very much for coming.
Thank you.
Thank you, Coloplast, to put our heads together.